If you've ever walked into a doctor's office with hormonal symptoms, hot flashes, sleep issues, brain fog, or anxiety, and been told it's just aging, or handed an antidepressant without a deeper discussion, then this episode is for you. I am joined by the brilliant Dr. Marcia Harris, a board-certified surgeon and passionate advocate for women's health. In this conversation, we unpack the biases and blind spots in our healthcare system, particularly around how women in midlife are perceived, and what we can do to speak up, push back, and get the hormonal care we deserve. From navigating your first conversations about perimenopause to advocating for treatment options post-menopause, this episode is packed with insight, empowerment, and real-world strategies to help you reclaim your place at the center of your own healthcare journey. So come with me today and let's dive in. Did you know that our struggle with weight doesn't start with the food on your plate or get fixed in the gym? 80% of our weight struggle is mental. That's right. The key to unlocking long-term weight release and management begins in your mind. Hi there, I'm Rita Black. I'm a clinical hypnotherapist, weight loss expert, best-selling author, and the creator of the Shift Weight Mastery process. And not only have I helped thousands of people over the past 20 years achieve long-term weight mastery, I am also a former weight struggler, carb addict, and binge eater. And after 2 decades of failed diets and fad weight loss programs, I lost 40 pounds with the help of hypnosis. Not only did I release all that weight, I have kept it off for 25 years. Enter the Thin Thinking podcast, where you too will learn how to remove the mental roadblocks that keep you struggling. I'll give you the thin thinking tools, skills, and insights to help you develop the mindset you need, not only to achieve your ideal weight, but to stay there long term and live your best life. Sound good? Let's get started. Hello, and come on in. Welcome. And I'm just sending love out to all of our listeners, our Thin Thinking community. I hope you are having a wonderful beginning of your July. Oh my goodness, this summer is flying by already. And my husband and I are packing up our car. And we are going north to dog sit a nice little Labrador called Billie Jean King in this place called Sebastopol. Have you ever heard of it? You may have if you've ever visited Northern California. Well, not super Northern California, but around Sonoma County and Sonoma County, and that, so it's wedged somewhere between Sonoma and Bodega Bay, which seems like a really cool place. It used to be the place, if you don't know anything about Sebastopol, which I didn't until, a couple of weeks ago. It used to be the home of the world's largest amount of Gravenstein apples, and where tons and tons and tons of applesauce was made. I think a lot of those factories have now been turned into restaurants where you can go and taste wine and, eat a bunch of, stuff you would get up there in Sonoma County. Cheese, bread, a charcuterie or a charcuterie. How do you say that? I'm not even going to try. I've got a little sore on the side of my tongue, and it just is impossible to say that word. But anyway, you know what I mean? It's like that kind of food. So I will come back and I will report on my road trip and let you know how I navigated all that fun stuff and stayed healthy and connected to myself up in that crazy Northern California world. And I'm sure I'll be running around a lot with Billie Jean King, which I'm really looking so forward to. And I'll tell you all about that adventure and more story behind it later. But I really want to dive into my special guest that I want to share with you, Marcia Harris.
And she is just like a dynamo. We had a great conversation, and I'm just going to give you a little frame on who she is. She is a highly respected OB/GYN and women's health advocate based in New York City. And she brings over 35 years of experience as attending physician and instructor at New York Hospital, where she trained and mentored countless medical professionals in the field of obstetrics and gynecology. And, she was doing tons of stuff, which you are going to actually hear in this episode even before that. But for the past decade, Dr. Harris has served as the medical director of the Wellness Restoration Center in New York City, where she takes a holistic and integrative approach to healthcare, focusing on the whole person, not just the symptoms. And she specializes in menopause, ladies, and andropause, often called the male menopause, and sexual wellness, vaginal rejuvenation, and bioidentical hormone replacement therapy. So she is a trusted resource for professional women. Dr. Harris helps clients move from burnout to balance through personalized care, lifestyle changes, and root cause medicine. She's passionate about busting myths, as you will hear, and correcting harmful misinformation surrounding menopause, which it abounds, is plentiful, and believes every woman deserves to feel seen, heard, and supported on her hormonal journey. So I'm excited to share this interview with you. Hello, Dr. Marcia. I am so excited about our conversation today. Thank you for coming on the Thin Thinking podcast and sharing your wisdom with us.
Thank you. Thank you for having me.
I'm going to tell our listeners what we went through to get connected today, because both for being women of, like out there in the world doing stuff, you should have seen us trying to get connected on Zoom.
Well, I have an excuse. I'm an old lady kicking and screaming.
Well, I am over the age of 60, so I was not, I still have an AOL email address, so I'm a bit
I
of a
do
dinosaur.
too.
We're
I
the
do
AOL
too. I
club.
actually went to my 50-year medical school reunion exactly a month ago.
Oh my gosh. Wow. That's impressive. Good for you.
Yeah.
I hope there were a lot of people there, all being doctors. I hope they all stayed well and
Yeah,
survived.
some of them were with their canes and their hearing aids and everything else. But yeah, there were quite a few. Now, several people have died. A lot of people have died,
All
but
right.
there was, I was really impressed. Quite a few, and a lot of people came.
Wow. Well, you look amazing. And I just have to say that. And tell us about
Thank you.
you're very welcome. So you have seen in your 50 years then a lot of changes, probably in the medical industry. And tell us a little bit about your background and what led you to become an advocate for women's health within the medical system.
Absolutely. Well, as I said, I mean, 50 years ago, when I was in medical school, there were very few of us.
Right.
There were very few women.
Yeah.
And my class, actually, I went to Columbia College of Physicians and Surgeons, and my class was the first class with more than maybe 10 women.
Wow.
That's kind of when the tide started turning, you know? And, but even with that, by the time I finished medical school and started my residency, where I did my OBGYN residency at Cornell, the New York hospital, I was only the eighth woman to have ever gone through the program. New York
That,
Hospital is the second oldest hospital in the country.
yeah.
And I was the eighth woman ever to have gone through the OBGYN residency at New York Hospital. First Black one, but there were
Wow.
only 7 white women before me.
That speaks to a
That's
lot. That speaks
how
to,
far
that is
back I go.
crazy.
It's
But but it also speaks to you and your, obviously your, high ability to navigate the world of medicine and the medical world. I mean, that must have been quite an interesting ride then, as the first Black woman in this program.
Well, you can imagine, we're talking about the New York hospital on Manhattan's Upper East Side,
Yeah.
like one of the richest zip codes in the country. And it's interesting because I would go in to admit the patient to the hospital, and I would walk in with my white coat on, my name's on it, my stethoscopes around my neck. And I would say, "Hi, I'm Dr. Harris. I'm here to admit you to the hospital." And they would look me up and down and say, "Can I have the bedpan?" You know,
What?
I would give them the bedpan. I would take it away, come back and say, "Now can I admit you?" They'd look me up and down again and say, "Can you go bring me some towels?" And I would go get the towels and come back. I mean, when they ran out of stuff for me to do and I was still there, they'd look at me as if to say, "Why are you still here?" And I would go, "I'm Dr. Harris. I need to admit you to the hospital." And they'd go, "You're the doctor?"
Amazing. Amazing.
Okay. That's how far back I go. Matter of fact, in addition to that, there are men on staff, and most of them are all now dead, but there were attendings on staff who never scrubbed with me. They literally would, when I was a junior resident, ask for a senior. "Oh, I
Wow.
need good help with this case. I'm not doing this with a junior resident." And when I was the senior resident, they would go, "It's okay. I don't need good help. I'll take the intern through it," just so as not to scrub with me. But guess what? I was the administrative chief resident. So the last year, they didn't have a choice. They had to deal with me because I was in charge. Okay. So, you know,
I love it. I love it. That is a determination, and I love how things sort themselves out. So people always have to stand up to themselves. So that's so cool. Um, so in these years that you have been practicing and being out in the world of medicine, uh, what started the ball rolling then for you with advocating for women within the system?
well, that actually started it because it was obvious that, and this still goes on to this day, even though it is much better. But we are, women are treated as second class citizens. We're
Yeah.
literally treated as second class citizens. We are not involved in the research. They don't include us. 90% of the medical research is done on men. And then
Wow.
they treat us as if we're little men or younger men or smaller men, or, which is not true. We are
Right.
totally different, which is why there are so many things that apply to men and that are assumed that don't apply to us. For example, the whole cardiovascular thing, none of that research was done on us. And we're totally different. The signs and symptoms and things you look for example, with heart attack, is totally different between a man and a woman. Totally different. Men have crushing chest pain, shortness of breath. I mean, the symptoms that we recognize as the symptoms of a heart attack, Women have a little bit of pain in their jaw, maybe, or they get faint, they get dizzy, and maybe even if they don't black out, they brown out.
Mm-hmm.
And most of the time, most women don't have chest pain when they have a heart attack. So you
Interesting.
have to think of it. We're totally, totally wired differently.
Yeah. Well, I believe that 100%. Uh, so when it comes to diagnosis and treatment, then obviously, if doctors are working off of data that is skewed towards men, then they're diagnosing for men too. So they are not diagnosing for women.
They are missing things in women which should be picked up, but which are not because of the fact that they're not looking for it.
Got it. Wow. That's stunning. So other than lacking data, what is, as a practice? Like, I think I hear women because, most of my listeners are women and most of my students are women. And, I myself have had to navigate the medical system. And, if I wasn't a loudmouth and didn't advocate for myself, I could have been brushed aside many, many times. And not just by men, by women as well. But I think that just the way that the frame which through which practitioners often see women is a different frame than they see men. Why is that?
It is. We're also, one of the other things we're also thought, and it's not really true, but we're thought to be not hyper. What word do I use? It's thought that, okay, she's exaggerating.
Right.
This really
Hysterical.
couldn't be so. You know, we are dismissed a
Mm-hmm.
lot more than men are.
Mm-hmm.
We
We're
are
more
totally
emotional.
dismissed a lot more than men are. And I
Mm-hmm.
will give you an example. The um, my cousin was hospitalized with, and she just browned out. She didn't have, she didn't faint. She wasn't even really dizzy. It was, she describes it as somebody pulled a curtain. The,
Wow.
the, the room got dark. The room got gray. She didn't even use the word dark. The room got gray and took her pulse, and it was racing. No chest pain, no shortness of breath, nothing that you would have expected. And did an EKG, and her heart was 140. And they said, oh, you're in atrial fibrillation. Took her to the hospital, admitted her to the hospital. The EKG, other than the rate, was basically normal. There were no flipped T waves. There were no, PR. There were no signs on the electrocardiogram of an actual heart attack, but something was obviously going on, and this was not there before. They broke the rhythm. They did. She was in the hospital for 4 or 5 days. They did all the testing. Echocardiogram normal, nucleus stress test normal, carotid Dopplers normal, calcium score normal, you know, did a full cardiac workup and told her everything was normal, sent her home. Now sent her home on medication, including blood thinners because of the supposed atrial fibrillation, but, sent her home. About 6 months, and it took 6 months. 6 months later, had a similar episode. Again, was admitted. Again, all the tests were normal, except this time the test that showed heart damage was elevated. This time. First time it wasn't. This time it was. But there was still no evidence of this heart damage. And again, they sent her home. 2.5 months later, there was a third episode. And again, they did everything. This time they even did a CT angiogram. They injected the dye and took pictures of the heart and told her everything was fine. I got there to visit the Friday night, and the doctor came in and said, "You can go home tomorrow. We're putting you back on your meds. I know this is the third time, but everything is still okay." And I said, "No, you're not sending her out of here, because she might not make it in the fourth time." And the doctor looked at me and said, "Well, then we're going to have to actually go into her heart and do an actual catheterization." And I said, "Okay." And she looked at me as if to say, "Do I really need that?" And I said, "Yes, you do." Guess what? Her right coronary artery was 90% blocked.
Wow.
90%. And I
And they,
looked at them the next day and said, "You all need new tests,
yeah,
or you need to interpret the tests for women differently."
yeah. Wow. Do is
90%.
Could they have picked that up with any other test
The,
other than
the, the
going in and
gold
doing an
standard,
exploratory?
and they really had gone the entire progression. The
Right.
first thing is an echo, which was fine. The second thing is a nuclear stress test, again, which was fine. Her ejection fraction, which is supposed to be 70%. Her ejection fraction was 67%.
Hmm.
Okay? There are people walking around with ejection fractions of 20 and 25 and 30%. Hers was 3 points off the normal. It appeared to be okay.
Yeah.
Women are different than men.
Yeah.
And we need to make that distinction and have that distinction be carried out and played out in the testing that we do and in
Hmm.
how we interpret the tests.
Wow. That's crazy. So obviously she was very grateful to you for advocating for her.
Yeah,
um,
I'm just very glad I went that night, because if not, she would have been sent home. And I'm
mhm.
serious. She might not have made it in the next time.
Oh, it sounds like
90%
it.
block.
Yeah, that is insane. So having said that, then where do you think, you know, I know you've been a gynecologist your entire career, correct? So, and so you're really working within that world, but I'm sure. So I guess the question I was going to ask you is, given what you're saying, and you're primarily working with women, where do you see a lot of misdiagnosis or lack of testing or interpretation within the medical system within gynecology? Like, I'm assuming there's a lot of
Well,
it there too.
there is, but at this point, for the last what, 12 or 13 years, I have done very little gynecology. What
Okay.
I have been doing actually has been menopause, hormones, vaginal rejuvenation, sexual dysfunction. I've actually, I don't operate, I haven't operated in 13 years. I haven't delivered a baby in 20 years. I haven't operated in 13 years. And in the last 13 years, I have been doing mostly menopause.
Well, do you see
And
a lot of misdiagnosis within menopause? People,
absolutely. It's, as a matter of fact, that's kind of one of the reasons I actually, super specialized in menopause was myself. Because
oh,
when I
okay.
went through menopause, I became non-functional. I
Oh, wow.
literally could not function. I was miserable. I had 20 hot flashes a day. I woke up in a pool of sweat every single night, 2 or 3 times. I had to change the bed. My libido was gone. I had no energy. I mean, I had, of the 34 usual and customary symptoms of menopause, I had 30.
Wow.
And 15 of the 30 were severe,
Jeez.
to the point where I was non-functional. And at that point, I literally had to find something that worked for me, or I would not have been able to continue doing what I do. So that's actually what sparked all of this and what got
Interesting.
me to where I am at this time.
Wow. So that it was your journey, and how did your journey progress with finding the answers?
Well, first of all, we dismiss women. As I said at the beginning, we don't listen to women. And I will tell you, I had a 44-year-old perimenopausal woman come in to see me about 6 or 8 months ago. She had seen 5 different gynecologists, 5. She had waited 6 months to get an appointment with the head of the menopause clinic at one of the premier New York institutions. And all 5 gynecologists, 3 of whom were women, dismissed her. Uh, you're too young. You're too young. I'm sure. It's not even perimenopause yet because you're only 44. Her
Really?
periods were regular, and a lot of times, gynecologists, they will tell you your periods are regular, therefore you couldn't possibly be. But menopause, perimenopause, starts sometimes as much as 10 years before you actually go through menopause. So
Mm.
that's a myth. That is not true. She saw this woman, and this was a woman, the head of the menopause clinic. She listened to her, did not draw one tube of blood, did not examine her, listened to her, and said exactly the same thing all the other 5 doctors had said. It's too early. You're too young. Here is, and she gave her a prescription for Prozac, a prescription for gabapentin, and a prescription for Veoza. So she gave her an SSRI, she gave her an antidepressant, okay, as well as something for her irritability, anxiety, and brain, and then something for the flashes and the other symptoms she was having, and said, come back in a year. Her friend said to her, I've been telling you to go to my doctor. And that's when she came to see me. Over the next 2 months, when it literally took about 2 months to get her controlled and straight, and she came back and blessed me. Like, thank you, thank you, thank you, thank you, thank you. You know, and that's where we are, and that's what I'm seeing. But
Was it a
again,
matter of, is that something that, if I can interrupt, if you, so your intervention was you examined her, you drew blood, and you saw imbalances that could be balanced. Is that correct?
that is correct. That is correct.
But these 5 people were just like, you're not, I'm not even going to spend my time with you because
You are
you're too
too
early.
young,
That's
is
crazy.
what they told her. At 44, almost 45, you are too young. Perimenopause normally starts 39 or 40. And
Mm.
as I said, can take as much as 10 years. The average
Mm-hmm.
age of menopause is 51,
Mm-hmm.
the average age. So there are
Yeah.
as many people to the left of that 51 as there are to the right, you
Mm-hmm.
know.
Mm-hmm.
But that's it. You are too young. We literally we dismiss women. We don't listen to women.
Yeah. Well, and it seems like there's a lot of mythology in this whole world of menopause and women's going through this. Like, what are some of the other like major mythologies about menopause and
About menopause
post
specifically, oh my gosh,
and
where do I
postmenopause?
begin?
Because Dr. Marcia, I'm sorry, Dr. Marcia,
That's okay.
a lot of our listeners are, you know, like maybe perimenopausal, but a lot of them are menopausal and then postmenopausal. So where are the mythologies, or where would somebody like who's frustrated and going to their doctor and they're saying, you know, look, I'm you know sweating every night, or I you know I'm irritable all the time, or I'm gaining weight, or I'm what uh you know what is being misdiagnosed, what is not being seen?
We are ignoring, we meaning doctors, are ignoring the symptoms and telling women, number one, you're too young. Number two, it's all in your head.
Mm-hmm.
That's another, you know, it's all in your head. And which is not true, by the way. You know, it really isn't. And they're not too young, as I said, because it starts as early as 35 sometimes, but definitely by 39 or 40. The other things that are being told is, listen, maybe you're in perimenopause and you're even close to menopause or even menopausal, but you just have to tough it out.
Mm-hmm.
The symptoms will eventually go away. Now, that would be okay if it wasn't such a travesty, because our hormones are responsible for more than 400 functions in our bodies. There are hormone receptors on every single cell: brain cell, skin cell, heart cell, bone cell. Every cell in the body has hormone receptors, not just the estrogen and progesterone and testosterone. Yep, women have testosterone. Not just those, but the cortisol and the insulin and the androstenedione and pregnenolone and all the other hormones. The thyroid is the master gland. I mean, that's what controls our metabolism and all our body functions. Women, all of those symptoms can point to thyroid disease, but you have to look for it. And women are dismissed.
Do
Okay?
tests for thyroid? I've always wondered this because I've had a lot of women say, "Well, my thyroid was tested and it was fine," but the range seems to me like it might be off.
Two things. One, the range is a problem. But the second thing, and this also has to do with the range, when somebody tells you a test is normal, which is what I do now in functional or integrative medicine, makes such a difference. Because if you draw a bell curve, 15 degrees to the left, when your value is less than that, the doctor will tell you you're deficient, you don't have enough. And 15 degrees to the right, when your value is above that, the doctor will tell you you have too much. There's a whole 150 degrees in the middle. Now, you tell me, vitamin D, which is critical, by the way, for our immune system. Every time I talk to anybody, I make sure that they get tested and that they get put on vitamin D. 85% of the people who died with COVID were vitamin D deficient.
Wow.
Okay? Vitamin D, they'll tell you you're normal between 33 and 100. So you've got 150 degrees, that whole top of the bell curve, but there's only 15 degrees to the left and 15 degrees to the right. Now you tell me, if you're 34, can you really consider that normal? No. You need to be not normal. And what we say in functional medicine is you don't want to be normal, quote unquote. You want to be optimal, which is the top of that bell curve. So with thyroid disease, a lot of times people will come in with the symptoms. First of all, most doctors just do the test called a TSH, which is the hormone, the pituitary hormone, which actually tells the thyroid what to do via a feedback mechanism. So if you do a TSH, you can miss up to 80% of thyroid disease. TSH is considered normal from 0.45 to 4.5 on that same schemata I just described. The top of the curve is 2.5. You need to be 2.5 or less. You don't need to be 3 or 3.5 or 4 or 4.5. Does that make sense?
Yes. Yes.
You understand? That's number one. That's if they only do a TSH. But there are a whole lot of other things that come into play there. There are antibodies, which you have to test. There's a whole panel of antibodies, which you can miss things like Hashimoto's, you can miss other autoimmune stuff if you don't test the antibodies. T4 and T3. T4 is the normal hormone that the thyroid makes. That's the one that gets put out into your bloodstream. It's like the ratio is like 95 to 5, 9.5 to 0.5. Okay. But the active thyroid hormone is T3. So you can have a perfectly normal T4, which is not getting converted to T3, and you're either hypo or hyperthyroid. Do you understand what I'm saying?
Yeah. So you're saying that the testing isn't going to show the full picture unless you're getting a panel of it.
There is a panel there are about 10 things in the panel. The pituitary and hypothalamic hormones, the actual hormones that the thyroid itself puts out, the hormones that it converts to, which is the active stuff. Then the things that block it, which are the antibodies. Then there's one called reverse T3, which again goes up when everything else goes down. You know, there's a whole panel. So you can't just do a TSH, which is what most doctors do. So women walk around sometimes for 5 and 6 and 8 and 10 years with thyroid problems when they could have been helped because no one's done the right test.
They're looking in the wrong places because they've been told they're normal.
Yes.
Right. So if somebody's diagnosed with Hashimoto's, because I hear this all the time, I've got a lot of Hashimoto listeners. Sometimes do you see them not getting the right treatment as well?
Absolutely. Absolutely. Hyperthyroid, Hashimoto's, autoimmune, the other autoimmune syndromes which come in there, literally a lot of times women. And the other thing is, for example, Hashimoto's and all the other autoimmune diseases, which by the way, women get much more than men. Those are the ones that are usually missed. And those, a lot of times, women are being told, it's in your head. It's in your head. Now, you know what I tell them? Yes, it's in my head. My hypothalamus and my pituitary are in my head. You're right. It's in your head.
Oh my God.
Okay. It's not in your head. You're not going crazy. It's in your head. That's where your hypothalamus
that's
and
what you
pituitary
guys.
are.
So how would you coach somebody on, or what would be your best practices for somebody going in and getting like if she's feeling dismissed by her doctor, like her doctor's like, yeah, you're fine. Yeah, it's in your
She
head.
needs to find a new doctor. Unfortunately, a lot of us have not been taught, even when it comes to menopause, all right? Not to switch sides or topics or
No.
systems, but a lot of us meaning physicians, have not been taught. Let me use menopause as the example here. At the turn of the century, back in the 70s, when I started doing this, we put everybody on hormones. Literally, everybody was on hormones. All right? And everybody was happy. Okay? And then in the late 80s, early 90s, I forget her name, the woman who was in charge at the CDC said, you know, we're doing this and we've been doing this now for a while. And we really don't have any studies to prove it because we used to say hormones help your heart. We now know that for a fact. We have the studies. We used to say hormones build and maintain your bones. We now know that for a fact. We have the studies. And we used to say all these things. Hormones protect your brain. We now know that for a fact. We have the studies. But at that time, we did not. It was just something we did and we assumed. So she, and I'm not faulting her, rightfully said, we need to do some prospective studies, going forward studies, so that we can prove that what we're saying and what we're teaching is correct. So that's how the Women's Health Initiative study came into being. And that was a national study involving centers all over the country. Matter of fact, it was like 166,000 women when it started in 1997, 1998. The problem, there were multiple problems with the study, however. First being the women that were in the study were actually older than 65. The average age of the women in the study was 65. 65. Now, based on what I said, in terms of perimenopause lasting as much as 10 years and then going into menopause directly, if our cells have not been getting what they need for 10 years, they're going to be damaged. So these women already had plaque on their coronary arteries. These women already had osteopenia and osteoporosis. These women already had all these things. That was number one. Number two, nobody that was actually symptomatic was accepted for the study. So if you were like me, who was flashing and sweating and all of the above, I would not have been eligible to be in the study. Now, how are you going to do a study on menopause and you're not including the symptoms? That's number two. Number three, the type of medication that was used, the hormones that was being used, was the horse's urine stuff. They didn't even try to hide it. And there are still women out there today where gynecologists are still prescribing Premarin, pregnant mare's urine. I'm sure 99% of these women don't know that this horse's urine they're popping every night before they go to bed. Okay? Premarin, pregnant mare's urine. Now, in all honesty, it's called CEE, the conjugated equine estrogen, which is the Premarin. This part of the study that was done where the women were given just the estrogen, those women did okay. Because even though the horse's urine was not the same as what our bodies make, okay, the key didn't fit the lock, but it was close enough that it actually helped. What this part of the study where everything went totally and completely all right was the part where they added in a synthetic progesterone. Now, progesterone is very, very important in terms of our female hormones because estrogen promotes growth, progesterone promotes development. If you have growth without development, you're in trouble, right? So the people who had the worst prognosis and the people who really got in trouble were the people who got the estrogen with the synthetic progestin. Now, the lost my train of thought. Edited.
Well, you were saying about the study that I'm assuming that the study was off because they were testing.
Yes. So the estrogen arm of the study, those people did okay. The estrogen and progestin arm of the study did not. That was number 3. Number 4, the study was not treated like most studies were. Most studies, you have you finish the study, they analyze the data, they put it together, they present it to the committee, they come up with their conclusions, and then it's presented to the medical community and subsequently to the world. What happened was a pharmacist, not even a physician, a pharmacist looked at it and said, oh my God, these women, this data shows that breast cancer went up. And without any consensus, without anybody else looking at it, whatever, he said this to someone, and the next morning it was front page New York Times and front page Wall Street Journal. Wow. Literally. Hormones cause breast cancer, or whatever the headline actually said. My phone rang 200 times that day. I can tell you where I was when John F. Kennedy was shot. I can tell you where I was on 9/11. I can also tell you where I was the day the Women's Health Initiative study was broadcast to the world prematurely. Now, was he correct? Yes. 2.34% of women in that age group get or are likely to get breast cancer. And it went from 2.34 to 2.90. 2.34 to 2.90. If you multiply that out, it went from 4 women in 1,000 to 4.8 women, call it 5 in 1,000. Okay. Now, tell me, is that statistically significant? No. It is not.
Yeah.
It is not. For the benefits, for the potential benefits of hormone replacement therapy, going from 4 cancers in 1,000 to 5 cancers in 1,000 is not statistically significant. And the sad thing is, all of these things were debunked within a year or two of the study being stopped, because that's what they did. They actually stopped the study in 2002 when this happened. And everything was debunked within less than 2 years. But whereas when it was announced, it was front page and headline New York Times, what happened when it was debunked, it was 2 paragraphs on page 50 of the same newspaper. The other thing is they stopped teaching about hormones. In the late 60s, early 70s, when I was in school, they taught us about hormones. We knew their benefits. We knew their risks. We knew what we thought they did and why they were important. They literally stopped teaching about hormones. So the crop of doctors who are out there now don't have a clue because they were never taught.
Mm-hmm.
So when the women go to them now and say, I feel lousy, please help me, they go, oh, you're getting old. It'll go away. You know, bear with it, stick with it, tough it out, which is totally, totally, totally unnecessary because the premise, the baseline premise is not true.
Wow. Can I ask you, so women go through menopause and then they're in postmenopause because I want, because a lot of my listeners are in postmenopause. What is, what are things that women are probably going to their doctor and complaining about that might just be some symptoms of menopause or postmenopause, but they're, they're just saying it to their doctor and their doctor is dismissing it?
Well, there are 34 primary symptoms. There are another 20 secondary, and there's about 15 or 20 tertiary symptoms. So there are a lot of things that can be and are associated with which women can complain of. Now, I'm going to go over go through the symptoms. However, even if and 10% of, let me back up, 10% of women are totally asymptomatic.
Mm-hmm.
And 10% are, as I was, very, very severe. The 80% in the middle are from one end of the spectrum to the other.
Mm-hmm.
That's number one. Number two, these symptoms usually burn themselves out, meaning they don't always, and there are 10% of people stay symptomatic forever, but the only 10% of the people in the middle, it might last, some people it lasts 2 years, some people it lasts 5, some people it lasts 10, some people it never goes away. So everybody's different in terms of how long your symptoms last. However, it doesn't matter if the symptoms go away or not, because of the fact that every cell in the body is affected. Even if the actual symptoms burn out and go away, your tissue is still not getting the benefit that it had for the first 50 years of your life. So is deteriorating as the hormone levels decline and go to nothing and are not replaced. Your tissue is getting, for example, estrogen maintains our bones. Testosterone builds our bone. As a matter of fact, in replacing hormones, we give women not just estrogen and progesterone, but testosterone as well. And a lot of times women are like, you're giving me testosterone. Isn't that a male hormone? It's not. Women have testosterone. Not only do women have testosterone, they have more testosterone than they have estrogen or progesterone.
Wow,
We have
interesting.
10 times less testosterone than men, but we have 10 times more testosterone than we have estrogen. And they're responsible for the same thing: muscle toning, building muscle mass, building your bone, energy, libido. They're responsible for exactly the same things. Okay? So when you're not getting them replaced, the decline in the hormones is actually affecting the cells in your body. The hormones are the difference between little old ladies pushing a stroller and women living functional lives into their 80s and 90s. The average age of death for a woman right now is up to 86 years old. Average
Wow.
age of death for a man is 79 to 80. And the difference is our hormones. Now, let me say here, the men start losing their testosterone way before we do, because theirs is incremental. Theirs starts as early as 20 and 25 or 29 and 30. But it's 1 to 2% a year. It's a steady decline. So even at 80 or 90, they still can have, quite a bit. Whereas we are fine, our ovaries work, they work, they work, and then we fall off a cliff and we crash and burn.
Mm-hmm.
That difference is why we function better, live longer, have less diseases, and get them later. For example, I'm sure you know a man who's had a stroke or a heart attack at 40 or 45 or 50 years old. And you're hard pressed to find a woman who has a heart attack or stroke before 60 or 65, because that's when the decline is significant enough, the hormonal decline, that the tissue has now actually reacted to it.
Interesting. Wow, that's fascinating. Now, I know we could go on for hours, Dr. Marcia, but I would love for you to tell our listeners, because I know you have a couple of things that go and get into more intricate details about menopause and how to take care of yourself. And maybe these are also something that they could advocate for themselves with their doctor with, the information that you're going to give them. Could you share that with our listeners as we kind of wrap up here? Because
Absolutely.
this has been really,
The
really helpful.
we actually we've cracked the code. We have cracked the code. We're rewriting the narrative. We're rewriting the narrative. We're flipping the script.
I love it.
We as women have to advocate for ourselves. Don't let anybody tell you it's in your head. Don't let anybody tell you you're crazy. Don't let anybody tell you you're making it up. You know how you feel. You know what you're feeling. If your doctor won't listen to you, find somebody who will. Find somebody who will. We know what's normal for us. We know when that's changed or starts changing. Find someone who will listen to you. My website is drmarciaharris.com. That's drmarciaharris.com. If you go in and fill out, it's a short form, I think email and cell number, and put in the memo, send menopause ebook, or there's several ebooks. So send menopause ebook, or send the ultimate menopause survival toolkit. How's that?
Put this in the
The
show notes
ultimate,
too, just so that our listeners will know that the two resources that you're giving them for free are going to be listed in the show notes so that they don't have to memorize this right now. And we'll
there you
also
go.
put your link to do that. So they just need to go in and put their name and their email address, and you'll send them some resources on menopause, hormones, and understanding what's going on a bit better so they can advocate for themselves more.
Absolutely. We really, as women, have to, because they will dismiss us.
Yes, I
We
think every
have to.
woman has a story, Dr. Marcia. I think every woman I've spoken to, I know has had a gone to the doctor and not been heard story. I know my doctor who my 23-year-old daughter has had those happen to her, and she's a young woman. She's not an older lady, so it's still happening, and I couldn't agree with you more. So I'm so grateful for our conversation today. I'd love to have you back and we can talk more about this. But I love the fact that you're arming us with your powerful guides. And please, if you're listening, check out Dr. Marcia. She's very knowledgeable. She's been around. This woman knows what she's talking
A
about. So
long time.
I love it. Well, thank you for your time and your knowledge and wisdom, Dr. Marcia. It's been wonderful, wonderful to speak with you.
Thank you so much. Thank you for having me.
Oh, wow. Thank you, Dr. Harris. And please, please go visit the show notes where you will find those resources that Dr. Harris was speaking about. And please also have an amazing and safe Independence Day weekend if you are here in the United States and listening to it this week. And if not, have an amazing weekend or upcoming week. And remember that the key, and probably the only key to unlocking the door of the weight struggle, is inside you. So keep listening and find it. I will be with you here next week. Bye.
Thanks for listening to the Thin Thinking Podcast. Did that episode go by way too fast for you? If so, and you want to dive deeper into the mindset of long-term weight release, head on over to www.shiftweightmastery.com. That's www.shiftweightmastery.com, where you'll find numerous tools and resources to help you unlock your mind for permanent weight release, tips, strategies, and more. And be sure to check the show notes